The supplementary motor area is just a place that I feel like we kind of glossed over in class, even though it's a pretty important area, and I'm personally fascinated by it, so I figured I would go back and address it here. Goals for this video is you need to be able to describe the anatomical location, the connectivity, and the functional role of the SMA, and how it contributes to internally generated movement and our sense of voluntary action. The image depicted here just kind of shows the connectivity between two SMAs over the corpus callosum. It is located in the just anterior to the primary motor cortex and is part of the motor association area, so it's not part of the primary motor cortex. And it plays a role in planning and initiating voluntary movement. And we discussed in class a example where disruption to the SMA can cause issues with remembering sequences of learned movement. The image on the right is more of a realistic representation of the connectivity, but it has heavy interconnections with the primary motor, somatosensory, and the premotor cortexes, so it gets input and it sends out input to those places. It also has outputs to the orbitofrontal cortex, the basal ganglia, and the spinal cord, and then inputs from the parietal lobe and the cerebellum. So it's kind of getting something from everywhere. It plays a role in internally generated movement and can become active before we're even consciously aware of our intent to move. And the duration of activation corresponds with the magnitude of the stimuli. So Cool et al. Discussed where if something really big, like a big sensory stimuli was around, then you would have greater activation and for longer than if, as opposed to something smaller. It also initiates voluntary actions and coordinates with, the prefrontal motor and sensory areas, and actually has drawn interest because of its role in free will. Huberg in 2021 went over what happens during surgeries and afterwards, and they noted that because the activity begins before we're consciously aware of the decision to move, and the consequences after surgery in the supplementary motor area, even though we have intention to move and they can't, it kind of suggests that the SMA is a gateway between the internal decision-making external motor output. So it raises questions about free will, but because it's such an abstract topic, there's nothing really there. SMA syndrome happens because of the surgeries and can happen because of stroke or injury, so like tumor resections or epilepsy surgery or stroke or injury. The symptoms are the transient contralateral hemiparesis, mutism, akinesia, impaired coordination, and difficulties with motor planning. So if you have a surgery in, say, your left SMA, then you would have basically paralysis on your right side, and you might not be able to talk. And obviously you're kind of, neglecting one side because you can't move. Even though you want to, and patients report that they still have the intention to move, and it's kind of like a disconnect between what they want to do and what's actually happening. But it usually resolves over the course of months. So because it's a motor area and something important like that, it has to have plasticity. So we do adapt, and it resolves usually with little permanent deficits, which is pretty fascinating. But you still have to be on top of your rehab, physical therapy and occupational speech therapy in case you were, having issues speaking, or, your physical therapy to keep yourself moving while you're recovering. Some other issues are alien limb phenomenon, which has brought a lot of interest because, it's kind of fascinating. It looks like purposeful movements, but it's not. And frontal lobe seizures is kind of a little bit misleading because they can happen anywhere, but ones that are specifically focal to the SMA usually happen and involve brief, frequent seizures with tonic posturing, speech arrest, or bizarre movements, and they usually happen in your sleep, which, isn't that great for epilepsy. You can also have speech initiation problems and motor neglect, and usually issues with the SMA look like Parkinson's, but obviously they're not. The speech problems are not aphasia, and you still have motor intention with the motor neglect. So the summary of all these things is that it's located in the medial frontal lobe and is just anterior to the primary motor cortex. It has dense reciprocal links with motor, sensory, prefrontal, and parietal regions and projects to the basal ganglia and corticospinal tract. It plans and initiates voluntary movement and sequences of learned movement and is active before conscious intent. It plays a role in free will, and because it precedes movement awareness, it can challenge traditional roles of volition. And SMA syndrome is a common result of surgeries or injuries there and can result in motor deficits and improves usually. And some other lesser known issues are alien limb and speech initiation problems, frontal lobe seizures, and motor neglect. And that's it.